Good evening, everyone. How are you all? Welcome to First Aid AMC Clinical free 2-week session. And I'm Dr. Arshan. So most of you already know me, and this is going to be our Psychiatry MSE Roleplay session, right? So I hope that many of you has already done our first class on psychiatry that we have taken, I think it was on 12th of November, right? So just 2 weeks ago. So tonight will be our first session on that free 2 weeks class. So all of you are aware that we are going to start our 5 months new course, and the new course, the starting day is today, which means you are actually doing our part of the course. So these classes that we are going to do is a part of the course, and this is a opportunity for you to get to know about us and also understand how we take classes. And remember, I told you that anyone can take 1 or 2 classes, and that might be really good because they might be just very good on that particular topic. But if someone can take 2 to 3 weeks class, and if you like those classes, that means you will like those classes for the next 3 to 5 months. So that's why we offer this 2 weeks free session for everyone so that you get to know about us and you can make an informed decision. And that decision is important because it's a long time that you are going to be with us, and we want you to be fully sure that yes, this is the right course for you, so that you don't feel that this is a waste of time after finishing the course. And I'm sure you will not feel that way because you can see our students are passing almost every month, and you can see that many months our students pass the highest number in the clinical exam. And interestingly, most of them are first-time attempt candidates. So that's actually where we thrive, because we make sure that our first-time candidate pass the exam. Because if we can do that, that means we are doing something really good. Because passing exam 3 or 4 times after is not a big deal, but passing clinical exam in the first attempt is a big deal. And that's the place where we put our efforts so that you can just finish this thing. This is a stressful time for all of you. When you prepare for clinical exam, you will need to make sacrifices. You will need to make compromises for yourself, for your family, for your job, everything. So that compromise or sacrifice should end up in something really happy and successful. And I will really appreciate if you guys join all those 2-week sessions that we are going to take. You already know our schedules. It's already given in our First Aid AMC clinical group. So just join those classes, have an idea, and if you feel that this is the right course for you, then join us. And I can assure you that this is not going to be the worst decision that you're going to make. And I'm sure that you will love it. As many of our candidates over the last 3 to 5 years, they loved it. They joined the course, they made friends, they made a very good outcome out of this course, because you get to know a lot of other people from lots of other countries as well, right? So let's not make it much longer. Now, first thing that I would like you to know that tonight is about role play session, and we take role play session every week. One of the class will be just role play session like this, and the other 2 classes will be theory sessions. Okay, so 3 sessions in a week where 2 are the theory based or cluster wise discussions, and 1 class will be role play session. So there will be a plenty of time to do role play with us. Excuse me. So this is one of the class tonight, is that first we do a theory session, and after that theory, we do role play on those cages so that you understand how the cages can appear in the exam, and how the theory session can be helpful in doing the cases in real exam. Okay, so that's the main thing. And also there will be another type of role play session which will be taken by Dr. Cynthia, one of our other mentor, who is going to do the recent important cases with you. And that way you can learn how to do random role play with us. Because in exam, you will get random cases. Out of nowhere, a case can appear in front of you and you will have to do that case. So Dr. Cynthia's classes will be focused on that particular part so that any random cases comes in front of you, you know how to deal with that. Okay, so that's how we divide the classes. We make theory sessions based on clusters. So cluster means that, let's say when we are going to do the cardiology session in few days time, you will see that in cardiology, we have a particular cluster like syncope cluster, or we have palpitation cluster. And you can just use single history format to do at least 6 or 7 cases. So that's the cluster-wise approach that we follow, and it becomes very easy for you to grab it and use a single format for multiple cases. And your effort, your time can get shorter and concise by doing that. A lot of doctors don't know how to do that, and their preparation becomes very complex and very time consuming. That's one of our thing, that we do a cluster-wise theory, and then based on this theory, we do role play. And another one is just a random one. So tonight we are going to do a cluster-wise one. That means we had a theory session with you. So we are going to do a MSE role play. So MSE means mental status examination. Many of you might not have attended that class. So if you haven't done that, that's a vital one to understand today's session. So make sure go and listen that video recordings. It is already given in the YouTube and also in our Facebook group. Just make sure you go through that. It's a vital part of your psychiatry preparation, because you can use that single psychosocial history in all psychiatric cases. So that's very important. Now let's start the role play. So how this works is that you can just say that you want to do role play, and then I will unmute you. And then we will just start the process, and you will get to understand how this works. And this is something which you guys also need to do when you are preparing. That means when you are doing role play with your study partner. Okay, let's start. So who wants to do tonight's first role play? Okay, so yes, so Dr. Maha, you can do it. Let me just give you a case. Just give me 1 second. I will just unmute you, Dr. Maha. I will appreciate if our, not just because I can see many of you are already have done our course. So I would appreciate if someone new do the role play with us. Okay. So tonight class is mainly for new people. So if someone new wants to do role play, I would welcome that, because that's how it usually works. Dr. Maha, can you hear me?
Yes, doctor. Good evening.
Okay. Just good evening, Dr. Maha. How are you doing?
I'm doing well, doctor. Thank you.
Good. All right. So let me give you a case. Just 1 moment. So this is your case. So how this is going to work is that normally you get 2 minutes outside and 8 minutes inside to finish your station. But as part of our course, what we normally do, we give you 1 minute outside and 7 minutes 30 seconds outside inside. So that you know that how to manage the time well in the exam. Okay, so you will get 1 minute, Dr. Maha, in the outside to read this case, and then 7 minutes 30 seconds to finish it. Okay, so your time just started.
Okay.
All right, so this is your patient. Your patient name is Sam. You can start.
Okay. Good afternoon, Sam. I'm Dr. Mahalakshmi, one of the attending GPs today. May I know what's your concern for today's consultation? Hello, Sam?
Nothing.
Are you with me so far?
Nothing.
Okay,
Yeah.
so I can see from your notes that you have been trying to hang yourself. So I'm
Just let me
I'm very
die.
sorry for that.
Just let me die. I don't deserve this life.
Uh, I can see that you're really sad, Sam. I'm very sorry for that. But I want you to know that we are here to help you. So if you want to talk about what's making you really stressed, I'm here with you. So
There is
yeah,
nothing to talk.
let me assure you that whatever we
Just
talk
don't
today,
waste my time.
um,
Just let
yeah,
me die. This life is not needed anymore. I don't deserve
uh,
to live anymore.
I'm sorry you're feeling that way, but um, yeah, just make yourself comfortable, and I want to assure you that whatever we talk today, it'll be between you and me, unless it's harmful to you or others. So yeah, tell me, Sam, how is your mood now? Sam, are you with me so far?
I don't feel like living. I feel very low all the time.
Okay, I'm sorry for that. And um, how is your sleep and appetite?
I don't want to sleep. I can't sleep because I can see that patient's dying in front of me, and I kill that patient.
Okay, so you are feeling guilty that a patient has died in your care, right? So,
Yeah, I know that
okay.
I could have I could have saved that patient, but it's just
Okay.
my fault that this patient is no longer here.
Mm, all right. So you are having problem with going into sleep, right?
Yeah, I can't sleep.
Okay. And have are you having any passing thoughts of harming yourself or anyone else?
Yeah, I just want to end this.
Okay. So have you thought about any definite plan to commit suicide?
Yeah, I will just maybe hang myself or just overdose myself with something.
Okay. Other than this, have you previously tried to end your life?
No.
Okay. So, yeah, now I'm going to ask you some basic screening questions that might seem quite strange. So, is that all right with you? Do you want me to continue?
Yeah, you're just wasting time, doctor.
Uh,
Just let me end this.
I'm so sorry, Sam. You feeling that way, but just I'll try my best to help you with this. So, uh, shall I continue?
Yeah, sure.
Okay. Yeah. Do you see, feel, or hear things that others don't?
Oh,
All right. Do you think that someone is trying to control you, or someone is controlling your actions?
no.
Okay. Do you think that people are talking about you?
Yeah, I can see that all the nurses are talking about me and they're saying I'm a murderer. I know that they're talking about me.
Okay. Um, do you think that someone is spying on you or trying to harm you?
No,
Okay. Do you think that you have some special power?
no,
Okay. Do you think that someone is inserting or withdrawing thoughts from your mind?
no,
Do you think your thoughts are being broadcasted?
no.
And yeah, let me ask you some more questions. Do you think you need some kind of medical help right now?
No, doctor. I just want to
Okay.
end this life. That's all.
Okay. So, suppose if there is a fire in this room, so what will you do?
I'll just stay and let the fire burn me.
All right. So, yeah. What's the date today?
I don't know who cares about the date.
Okay. So, do you know who I am and where are you at present?
Yeah, I'm in the hospital. You're the doctor.
All right, Sam. So, I would also like to know about your home situation. Is there any stress at home or anywhere
No,
else?
my wife is very supportive.
Okay. Yeah. Do you smoke or drink alcohol or any other recreational drugs?
No,
Okay. Yeah. And okay, do you have any previous history of any kind of illness or any mental illness?
no,
Okay. Is there any family history of any mental illness?
no.
Okay. Do you recently had
Time
any
up.
head injury?
Time up.
Okay.
Time up. All right, Dr. Maha. Why asking this much question?
Yeah, I actually lost the count of time. So yeah, I actually have to present
Yeah, that's
the
right,
exam
right?
MSE in the time, right?
Yes.
Okay.
Yes, you have to. And they will not ask you to move to the next task. They will not give you anything. When time is up, it is up. All right. Now
Yeah.
always remember that when you questions in the exam, you will
Mhm.
know that you're running out of time because that's how it works. When you
Okay.
actually ask about home situation, that's the time you
Mhm.
should have stop there and then just go for the MSc presentation. Now, when you have just MSc presentation, there is no need of even going to the lot of home situations, SADMA, family history. It's not like must. When you think that
Okay.
it took a lot of time, especially for a depression patient like this, in exam it takes much longer time because I was giving you answer almost instantly. But in
Mm-hmm.
exam, they will not, they will just sit there. They will not talk, they will not answer you. Maybe just after a few seconds, they will answer your question. They will be very slow. Like you will be dying there just for them to say something. So
Mm-hmm.
that means that this case will be slow in the exam. And you can't ask the patient that, Sam, are you with me? If I am not answering, don't say that, because it means that you are showing that you are very busy and you are mainly focusing on your time. So don't do that, especially for this case. So if Sam is not answering your question because he's very sad, and that's why he's not wanting to do that. Okay, so never ever in a depressed patient, if they are not answering your questions, like just instantly, don't say that, Sam, are you with me? Can you answer me? So
Okay.
never ever like that. So just wait for them to answer. That's the reason you will actually not get too much time in these cages. So don't bother with SADMA, all of those, because that's not a part of your MSc presentation. Your part of the MSc presentation is aseptic J3R. As long as you have asked all those questions, you are good. Just finish the presentation, because if you don't touch this point, they will
Mm-hmm.
fail you. Okay,
All right, doctor.
that's
Yeah.
the most important part. Now, other than that, change the tone of your voice initially when patient looks very sad to you. Like if I were in this place, I would say something like to show that I'm actually very empathic to the patient. So I would say, hi Sam, this is Dr. Maha. I'm one of the doctor here. Sam, I can see from the notes that something happened at your home. I'm very sorry to hear that, but I want you to know that I'm here to help you. And I'm sure that something really stressful going on with you. And that's the reason why you ended up doing that. But you don't need to feel alone. Let me help you. I would like to ask you a few questions, but I would like you to know that everything that we are discussing today, it is confidential. You can take your time, Sam. I'm here just beside you. When you feel comfortable, please tell me what's happening so that I can help you. Okay, so something really meaningful so that actually patient understand that this doctor is trying to help me. So changing the tone and the way of your talking is a very special art that everyone likes. Examiner also looks something like this in a candidate. Okay, so always in these sort of cases, especially psychiatric cases, you should change your voice, your tone, your way of talking. Because if you say that I'm very sorry that you are having this, but your tone does not show that, it means just you just memorize something and you're just saying that. Okay, so the important thing that I always say that mean what you are saying to the patient. Okay, so that's for everyone, not just for Dr. Maha. Is I know that most of the candidates would not value this part of the conversation, but this is a very important thing. Okay, so do that. And other than that, in your history, I think that everything was fine. You asked about all the questions that is relevant for this case, like aseptic J3R. One of the other thing I would say that for a depression patient, don't bother about all the RC GGP question for depression. Like you don't need to ask them that, do you think you have a special power? It's very
Mm-hmm.
unlikely that they will have that. So forget about that question.
Okay.
Okay. And one of the important thing that when I say that I can, I know that all the nurses talking about me and they're saying I am murderer. It is a very important thing that you need to go a little bit detail about it in the exam, because you need to know that what this actually means. Is it a hallucination? Is it a delusion? Or is it actually this happened? Because sometimes if you ask a little bit deeper question in here, patient will say, like, let's say that when I say that I know that they are talking about me and they are saying me murderer. The next question is, Sam, I'm very sorry that you're feeling this way. But can you please tell me that, did you actually hear them saying that? Now, that's a very important thing, because then patient might say, no, I haven't heard, but I know that they are doing that. What does it mean? It means that this is most likely patient thinking that others are talking about him. That's what we call as delusion of reference. Okay, so that's one of the important thing that you need to find out, that what actually patient is trying to say to you, because that's one of the positive point that you need to present to your examiner during MSc presentation. All right, so other than that, everything is good. Now, Dr. Maha, I would give you a chance to present this MSc if you can. And just for appearance part, because you can't see me, just say that appearance is sad and gloomy, just relevant to the case. Okay, you can do that, Dr. Maha. I will unmute you.
Yeah.
So start.
Okay. So in the appearance, yeah. Examiner, I would like to present the mental state examination of my patient, Sam, who is a nurse, and he's bought by his wife as he was trying to hang himself with a rope at his home after his patient died in his care. So, in the appearance and behavior, uh, the patient is well dressed, and he's sad and gloomy, and he he's cooperative, and he maintains eye contact. And coming to the speech, his speech is normal in rate, volume, and tone. And his mood is low, and his effect is congruent to his mood. And there are no hallucinations or any abnormalities in the thought form or content. And he's oriented to time, place, and person, and he lacks insight, and his judgment is also impaired. Uh, and yeah, I can see my patient is having risk of suicide. Uh, and yeah, he's maintaining a good rapport, and I think his history is reliable.
Thank you, Dr. Maha. You did good. The only thing is that thought form, you should say linear, and thought
Okay.
content will be, this patient actually has a two thought content problem. Anyone?
Delusion of guilt, doctor?
Yes, delusion of guilt, very good. And the other one is delusion of reference. Okay. All right, so that's the important part, right? If you don't say the specific positive point in the exam, you will fail the MSc case. They are very picky about it, because not too much of the positive points will be there. But if you miss these particular ones, then they will fail. Okay, so be very careful about these findings and understand what they actually want to do and what they actually trying to give you. So those positive points are very important to find out. Okay, you did good, Dr. Maha. Thank you.
Doctor, I have a question, a doubt actually.
Yeah.
Suppose the patient is not answering, like whatever the questions, maybe he's not responding. So, what should we do? Like, should we wait for him to answer, or like, should I go ahead and present the MSc?
No, usually you would just break the ice, which means that sometimes you will obviously give them a little bit of time. But if you think that they're taking a long time and they are not interested to answer that particular question, you just move to the next question. And during your MSc presentation, you say that patient denied to answer that question. Okay.
Right.
So many times they will do that, and you will give them a little bit of time, but don't poke them that, can you tell me what's going on, or are you with me so far? Don't poke them. Just move to the next task or move next question. And then during your MSc presentation, if it is important, then just say that patient did not answer that question. That's fine.
Okay. So even if the patient is agitated and he's like irritable also, we should try to calm him down. And if it doesn't work, we should go with MSc presentation.
Yeah, not like MSc presentation. You should just move to the next question.
Okay.
Because you need something for presentation. If you don't ask any questions, then you can't do the MSc presentation. So you will need to finish the whole questionnaires. You will ask them, but if patient does not answer you, then you just move to the next question. So, and then after you have asked all the questions, then you move to the MSc presentation.
All right, doctor. Thank you.
Okay, no worries. Thank you, Dr. Maha. Okay, so that was one of the very commonly asked case. So if I just did this MSc presentation for you guys so that you have an idea that how we normally do it for someone who did not join our last session. So we normally say that, dear examiner, I would like to present mental status examination of my patient Sam, who is a nurse brought by his wife because he was trying to hang himself with a rope since a patient died during his care. In terms of his appearance and behavior, he is dressed appropriate to the weather, he is well groomed, but he looked very sad and gloomy. He was not maintaining eye contact throughout the conversation, but he was cooperative. There was no other abnormal behavior that I have noticed. In terms of his speech, he was slow and sometimes speaking by giving some pauses in between. Many times in depression, the speech that you normally look for is called slow, monotonous speech and taking pauses in between. So my patient's speech was slow and monotonous and taking pauses in between, but there was no disorganized speech or flight of ideas, or you can say there was no disorganized speech or rapid pressured speech. So negative points also we say in the exam so that examiner understand that we know what to look for. Emotion in terms of patient, it was low, and the affect that I have noticed, it's also congruent with his mood. In terms of his perception, there was no visual, auditory, or tactile hallucination. Thought form was linear. In thought content, he had delusion of guilt and delusion of reference because he had feeling of guilt because he think that he has killed one of his patient, and also he was thinking that other nurses are talking about him. But there was no other delusions. Insight and judgment was impaired. His cognition was intact to place and person, but not to the time. He is a high-risk patient because of active suicidal ideation and also active delusion. I was able to maintain a good rapport with my patient, and I think the history is reliable. Okay, so that will be your MSc presentation in here. Any question, guys? Can we move to the next task? Now, normal guilt and delusion of guilt, the difference is that if you ask a little bit about this, that can you please tell me why do you think that this patient died because of you? Patient, and then if the nurse says that, well, you can patient died of meningitis, and I was a little bit delayed to check his temperature. Now that actually should not just kill the patient. And a nurse is not supposed to kill a patient unless if the nurse has given some wrong dose or wrong antibiotics, something like that. So if they think that for them a patient has been died, that's actually abnormal belief. So you just need to get the idea that what kind of belief the patient having. If a doctor think that because he could not find the correct diagnosis and that's why patient is dead, yes, that's a normal guilt. But if a nurse think that he could not save a patient, that's something which is not right all the time. So if possible, you can go a little bit detail about this. Like, can you please tell me that why do you feel that for yourself the patient is dead? Then you will find out that patient will say something which actually should not kill the patient. Okay. Grandiosity is the special power. Special power or delusion of grandiosity is not needed for depressed case because they should not have a special power. So it's not a relevant question. If patient is not cooperative, you can take history from the wife, but in exam you just get one role player. So there is no other way but to take history from the role player only. You don't need to talk about the diagnosis in MSc presentation unless your task is diagnosis. Okay, so never ever bother about giving diagnosis as part of a MSc presentation. All right, any other question? Anyone in the Facebook who are in the live, do you guys have any question? You can always comment, write in the comment box. I'm going through that anyway. Good. Now let's do the next role play. Who wants to do next? I would say if there is anyone who hasn't done the course yet, just please come and do it with us so that I can get to know about the new people. Okay. Okay, so yes, Mabruka, you can do it, and after Mabruka, we can see that Numra, you can do it. Okay, so let's start with Dr. Mabruka Islam.
Hello, doctor.
Hi, Dr. Mabruka, how are you?
I'm good, thank you. Can you hear me?
Yeah, I can hear you nice and clear.
Okay.
Okay, just 1 minute, I'll give you the case.
Sure.
All right, so that's your case. Oh, sorry, just 1 second. Okay, so this is your case.
Mhm.
Your 1 minute time just started. All right, so this is your patient. Your patient's name is John. You can start.
Hello, John. Nice to meet you. This is Mabruka Islam. I'm the attending doctor today.
Nice to meet you, doctor. It's very good to be here today. I know that you were just here to talk to me, but I just don't have any time, doctor, to talk today because I'm just very excited about my new discoveries. And I know that the school counselor is just giving you some bullshit to talk about me. Don't worry about me because you have a lot of other patients to talk to. So don't waste your time at all for me because I have much important things to be done. And just say the school
Okay.
counselor that you have talked with me and I'm fine, so that they don't also bother you. They are just
Yes.
jealous about my discoveries. That's all. Because they don't know that a 19-year-old can do such a discovery because I'm going to change the Newton's law. And they just think that I am a crazy person. But they don't even have the idea. They don't even know me. They don't even think like me. So the students are jealous about me. The counselors, the professor, even he is jealous about me and he wants to steal my idea so that he can publish it and get the Nobel Prize. I'm not going to let him to do that. So,
Yeah,
so that's
definitely,
actually
John.
what's going on. So,
Okay, all right. I really appreciate and thank you, John, that you are coming up with all the information that you shared with me. Really appreciate that. So, John, from the note, actually, I can see that your performance is downgrading. Can you please tell me a bit more about it?
oh, who cares about the school when I can discover Newton's law, when I can discover new planet in the solar system? Who cares about the school performance? The
Okay.
school results does not mean anything because it's just showing that yes, I'm doing my studies, but I am more than that. So just don't get stressed about it, doctor.
All right. So, John, can I know, please, that since how long you have this thought and that you are going to discover something new?
Just going on for the last 1 week, but I've never felt like this. It's just really, really good feeling. And I feel more confident now more than ever.
Definitely. Definitely. And John, may I know that anything happened before this 1 week? Any significant event that happened?
No, I was fine.
All right. And whom do you live with, John?
I don't live with anyone. Like no one can even understand me. So I just like to live alone now. And the other people also was there. My mates were there, but they just think that I am too much. So they left the place. So
All
now I have
right.
got an entire room and I can just think, I can do my
Okay.
things. In one side, I have the new discoveries, and other side, I also engaged myself with lots of community clubs, lots of arts clubs, science clubs, drama
That's
clubs.
great.
So I'm just in
Okay.
the best form of myself.
Okay, awesome, John. So yeah, this team seems very like innovative things that you are doing and very interesting, John. So may I know that how your mood these days going on?
It's absolutely brilliant mood. I can't say that how good I feel about myself.
Okay, that's great. And John, just asking that you know, sometimes under stress, we people see or hear some things that others people not. By any chance, has anything happened with you?
Doctor, you also think I'm crazy like the school
No,
counselor?
no,
He
no.
was saying the same questions.
No,
I'm
sorry,
not
just
crazy. It's just like
yes,
I'm different.
definitely. Okay, all right. Yes, yes. And do you think that the idea that you are having at the moment, is it gonna be stolen someone by someone?
No, but I'm sure that someone will come after it. But I don't think anyone knows about it at this time. But when they will know about my discoveries, I know that they will come after me.
And do you think that people are talking about you?
Yeah, everyone in the university are talking about me. They just think that I'm doing a lot of things and they're jealous
Yes,
about me.
definitely. And do you think that someone's spying on you?
No,
No, okay. And do you think that someone want to harm you?
no.
Okay, all right. So, John, do you think that you need any medical help?
Why? I'm fine. Why will need a medical help, doctor?
Okay, that's all right. And John, could you please tell me that where are you at the moment?
Yes, I'm in the clinic.
And what is the time? Is it a daytime or nighttime?
I don't know. I don't know,
Mm-hmm.
doctor. I just it's all over my head at the moment. I'm just keeping thinking about my
Mm-hmm.
discoveries, and things are just coming into my head
Yes,
all the time. So
yes, all
I
right,
don't have the time to look for the
definitely.
dates.
Yes, just few more moment. I'm not taking a long time from you, John. And do you know that who I am, who you are talking with?
Yeah, you're the doctor.
Okay. And John, by any chance, if you see that there is a fire in this room, what you gonna do?
There is a fire in the room. Oh no, I
Yeah.
can't die at the moment because I have a lot of discoveries to be published.
Yes,
I need to
definitely.
run.
Okay, all right. Okay, so John, may I know that do you have any family member around you?
No, no one even likes to talk to me.
Okay. And by any chance, did you have any suicidal ideation or self-harm?
No,
Okay. And any passing sort of suicide?
no.
Okay. All right. Thank you, John. Do you smoke, John?
Yeah, I've been smoking a lot these days. It's just like because I'm too much
Mm-hmm.
pressured, so it helps me to
Mm-hmm.
be calm.
And do you drink alcohol?
Yeah, a lot.
Okay, I can arrange another consultation as it's injurious to health with your consent. And any recreational drug by any chance?
Yeah, doctor, I'm just going to the nightclubs at the time because nighttime I just can't hold my thoughts anymore. So I'm going out in the night and doing some stuffs and
Any
taking
gambling
lots
by
of
any
drugs. Even I
chance?
don't know.
Yep, any gambling by any
Yeah, a
chance?
lot.
Mhm.
Yes, I'm spending a lot as well.
Okay, are you sexually
But that's
active,
fine.
John?
I feel good about it.
All right, are you sexually
Yes.
active, John? Okay, may I know that do you have a
Yeah.
stable partner?
Not at the moment. I'm just free single who is just going around and engaging in a lot of sexual partners at
Oh,
the moment.
are you practicing safe sex, John?
Sorry, I'm out. That's all good, Dr. Mabruka. I know that this is tricky in the exam, right? So even though
So
you know
actually,
all the
Doctor,
questions, yeah,
so yeah, my task is taking history. So I was like completed my MSc, but I was thinking if it is a history, should I go further?
yeah,
And then I start again questioning.
I know. So that's the thing, right? Now the thing is that when just history is there, actually they they actually want you to ask those history that you are asking. The main issue is just finishing the task
Task on
in
time.
time. Because when the task is just taking a psychosocial history, that actually means that you might need to ask a little bit of many questions also, which you are actually asking. So that's not bad or anything, but if the time running out, in that case, just don't bother with those histories. Okay, because you can still pass if you can present the MSc to the examiner. So it always
Okay.
depends on the case, because sometimes they might not bother you this much. Sometimes they might just answer your questions. If they don't, then don't bother with all the mania questions. Just come and finish the MSc presentation. And at the end, if you have some time, you can just go back and ask those histories. Okay, they will even pass you at this time. But if you don't finish it, then they can't pass you.
Definitely.
All right, now let's just say like what you are going to present to the examiner about MSc. I'll give you some time. So
Okay,
start.
so examiner, I'm presenting 19 years old John, who is an university student and referred by school counselor. So here I I found appearance is well groomed and well kept. Body posture was normal and maintaining eye contact, and he was cooperative. And on speech, I found it's a rapid pressure speech, which was high in volume. Mood was high, which is and the effect I found is congruent with the mode. And I could not assess. I could not found any hallucination as a perception. And in thought form, I found it was a flight of idea there. And on thought content, it was a reference, delusion of reference present. Insight was impaired. And on cognition, patient was oriented about the place and person, but not oriented to the time. Judgment was intact. Patient did not have any risk of suicidal ideation or harm to the others. Rep was good, but the history was still not reliable. I would like to take a parallel history from next to kin. Thank you.
Thank you, Dr. Mabruka. Brilliant, very good. So that was nice. The only thing that is missed in the presentation is that that there is always, remember that in case of mania, the main finding, yes, in case of appearance behavior, you will be looking for a restless patient. So you might just say that patient was quite restless as well. And then you should look in the speech. Yes, you will get rapid pressure speech. Then and also they can be very loud, and that means the volume can be increased. Emotion, yes, the patient will be euphoric, and then congruent will be like the affect will be congruent to the mood. Perception, there will be no hallucination. That's right. In case of thought form, yes, flight of ideas will be there. So you did that very, very good. Thought content, you had one is delusion of reference, another would be delusion of jealousy, another would be delusion of grandiosity, because grandiosity is a very important finding in mania. If you ask the patient, do you think you have some special power, he would get it. Okay, so most of the mania patient will have this delusion of grandiosity. So very common finding. So ask the patient and most likely you will get an answer to that. After that, so then inside cognition judgment you ask, so that's fine. This patient, in terms of risk assessment, you will have to say that, do you think it's a low risk patient, moderate risk, or high risk patient? So just say that, because this patient does not have any active suicidal thought, but is still having some active delusion, you can say that the patient is moderate risk. Okay, low to moderate, not severe. You don't need to say severe based on that, but low to moderate risk will be a good idea to say.
Yes.
And yes, you can say you are able to maintain a good rapport with the patient, and you need a collateral history from the school counselor or next of kin. Okay, good, very good. So in terms of this case, so everything is nice that how she has done it, but also Dr. Mabruka did not give the confidentiality statement initially, which is really important for this case. Okay, so
yes,
make sure you don't forget about confidentiality.
Yeah, I was confused at where to give it. Patient was so talkative, and yeah,
no, just give it. Yeah.
Okay.
Yeah, like even before asking any question, just give it. Okay, because that's a point, like a key point in the psychiatric history, and the examiner will give a tick to that part.
Okay. Thank you.
Thank you. So yes, obviously in this kind of cases, it becomes very hard because patient will be like a really, really talkative in this case. And you just need to keep your calm and keep your cool because people lose their calm in these cases. And you will just start asking questions from all over the place because patient makes you to do that. When someone talks and you know that your clock is ticking, you feel stressed and you get confused. Even though you know what to ask, you will get very confused and the case will become a little bit of all over the place. But Dr. Mabruka was good with that. So she asked all the relevant questions, but still it's important to make sure that when to stop. That's the thing, that if in your head, when you do a lot of role play, you will know that your time is up and you need to start doing the next task. So that only comes with a lot of role plays. Otherwise, no one can say that how to gain that feeling that your time is up. That's that you everyone who passed the exam, they know in their mind that what 6 minutes feels like, what 7 minutes feels like. So that comes with a lot of role plays. If you think that you can gain that without doing role play, that's a very, very wrong idea. Okay. So apart from that, everything is all right. So mood, sleep, appetite, and suicidal thoughts. The good thing, always say before asking hallucination question that I'm going to ask you some sensitive question that might feel very strange to you. So, okay, but these are very common questions to everyone. So patient will not get offended to that. So then you ask the hallucination question, ask the relevant delusion question, and then just move on as much as you can. Mania, there are a couple of important questions that we need to find out. When we do our psychiatric classes, like the other cages, we do the mania cages also. So then you will get to know about it. But to give you an idea, a mania patient will have some specific features. One of the features is their mood will be very euphoric. So I think we have a mnemonic also at the end. So if I go here, so this is the mnemonic that we follow for mania questions. So dig first. D is destructible, I for indiscretion, grandiosity, flight of ideas, increased activity, lack of sleep, and very talkative. But you don't need to ask these questions, all of it. The only important questions are in the mood you will be getting patients feeling very high. It's also important to find out that anytime do you feel very low? Because one of the differential for mania would be bipolar disorder. But if the task is only MSE presentation, don't bother. But if diagnosis DD is there, then yes, you will need to ask that question. You then ask about sleep. You will find out patient don't feel like sleeping. You need to also find out that patient started to spend a lot. You will also find out patients getting an increased sexual drive. So that's why sexual activity history is important. Then patient have this special power-like feeling. That's called 4S. Also, you will find out patient feels very energetic. So if you ask the patient, how is your energy this time? Patient will say, I feel very energetic. So couple of questions. How is your mood? So very high mood. How's your sleep? I don't need to sleep. How's your energy? Very energetic. Do you think you are spending quite a lot these days? Yes. Do you think you have some special power? And how's your sexual life? Are you sexually active? Do you have a stable partner? Then you will find out patients saying that there is increased sexual drive, lots of promiscuous activity at the moment. You might also find out that patient taking a lot of reckless behavior, like driving while drunk. So those reckless activities are a part of mania symptoms. So those questions will come. Now, the main thing is that when history is a task, we should ask these particular questions about mania, because by the look of the patient, you know that this patient most likely having manic episode. So that's the problem, that if you ask all those questions, you might run out of time. In that case, don't bother too much with who do you live with, any stress at home, just forget about it. you will need to ask the smoking, alcohol, and recreational drugs question here, because that's also can get increased in this case. Okay, it's about how you manage the time always. With role play, you will get the idea. If a patient is talking a lot, how Dr. Mabruka has done it, like she just say that, yes, that's fine, just ask the next question. Sometimes if in many a case, if the patient talks a lot and you know that you are running out of time, just say that, yes, that's all right. I can see that you are doing really good. You are not interrupting the patient, but you are giving a pause to the patient's lot of talking. And then you can go to the next question. Let's say art that you gain, how to stop the patient, but patient will not get offended to that. Okay, so just like when I am talking a lot, how Dr. Mabruka said, yes, that's great. So how's your sleep? So what you did that I could talk another 1 minute, but you just give a break, and then I did not bother, right? So that's how you save the time in here. But don't do a lot. Like if you just do a lot of this, then patient will get just or offended. So you will just need to make it in between, just give a little bit of pause or break so that patient don't feel offended. There will be no ring. You can't. The problem is, this is the problem in a clinical exam, because they don't give you any stopwatch, they don't give you any watch, so you don't know your time is running out. Okay, that's the main issue. So even in online exam, many times there might be a little bit of bell ringing, but bell ring usually happens if in the history it is written that take history for 6 minutes, then at 6 minute time there will be a bell. But if nothing is written in the task, then unlikely there will be a bell. Yes, you can call it mania because it's 1 week. And Dr. Jarian, the history can be anything. So I would say that go with the flow, but don't forget your format. Now you can say that, Dr. Bhavin, that you can say that it's a moderate to high risk. If you say that patient is abusing drugs, having unsafe sex, no insight, yes, you can say that. No, you don't need to say that, Dr. SK, that examiner does not need to know that you would ask a lot of questions. Only thing that matters that if you asked it. The MSE cages, the reason that people fail is you can see that most of the time they run out of time, and also that the approach becomes very different. So the approach is very important, where if someone does not give enough confidentiality, that case can be failed immediately at that time. So that's a couple of things which is very important. All good. So let's do another case. We'll do a different case now. So I think who I say that you can do the next one. I think Numra, right? Yes. All right, Dr. Numra, I will just unmute you.
Hi, thank you.
No worries. How are you?
Good, how are you?
I'm good. Thank you, doctor. Okay, so let me give you a MSc video, because we haven't done this yet. So do you have the idea that how the MSc video works usually?
No, I don't. No, I don't.
No?
I have never
That's
seen
fine.
an MSc video.
That's all good. So let's do that and you will get the idea and experience, because in face-to-face exam, MSc video comes very, very frequently. And it's an easy one to pass because you don't need to ask history. You just need to watch the conversation between the patient and the examiner. And then they allow you to watch the video for 4 to 5 minutes, sometimes 6 minutes. And then at the end, you will just need to present the MSE to the examiner about what you have heard. Okay?
All right.
So let's do that. So just give it a read because you can't think anything in here. So we will just move to the next one and where you can listen to the video.
Sure.
Okay. All right. So let me give you the time. Okay. So once we stop the video, you will need to start presenting the MSc. And
All right.
at this time, you can write whatever you want in the paper.
All
Okay,
right.
so your time just started.
Hello, Robert Smith.
Yeah.
Thank you for coming to see me today. I'm Dr. Stanley. I'm one of the doctors that works here. Obviously, anything that we say is confidential between us and the team that I work with and your GP who's asked me to see you.
Okay.
I hear there have been some problems with your housing. Do you want to tell me a little bit about them?
Yeah, I've had all sorts of problems. I mean, where do you want me to start? My neighbours,
Mm-hmm.
police, people spying on me in my street.
Sorry.
None of them will admit to it, but my neighbours, it's mainly them at number 9, but I've seen them talking to the ones at number 6 and across the road as well.
So when did things start to go wrong?
I don't know. I mean, you'd have to ask them. Well, like when they started properly, like deciding that they wanted me out of the street. I think it was a few months ago. Months. It's been going on for months.
What makes you think they want you out the street?
Well, it's the harassment. It's the spying on me, putting bugs in my house, in my phone. And that at first they thought I couldn't hear it, but now they know that I know that they're there. Saying things about me through the window. Talking about what I'm doing. I know they're doing it. Whenever I leave my front door, woman at number 7, she's always there. She's clocking where I'm going and what I'm doing.
Why do you think they're doing that?
Well, I don't know. They're just. I think they want me out.
Mm-hmm.
I think they're testing me, and they're trying to find out how far they can push me. Basically, it's all part of some test. I don't know why. I don't know what for. You'd have to ask them. That's what I've said to the police time and time again. I've said to them, why are you asking me these questions? Why don't you just talk to them?
You said that your phone was clicking. What was that about?
A landline.
Your landline?
Yep. Somebody rings me or I ring somebody. Between 7 and 10 seconds in, I hear click, click, click. Click, click, click every time.
Any other explanation for that?
I don't know. Well, it could be, but every single time, and then they're talking to me, and then they know what I've been saying down the phone.
How are they talking? Where are they talking to you?
Well, I can hear them next door. Oh, he's on the phone again. Oh, he's reading that book again. I can hear them saying it, and they know that I can hear them, and that's why they're doing it.
Okay, so just to summarise at this point, your phone's something's happening to your telephone. You can hear your neighbours talking about what
Yep.
you're doing, and making a commentary on your actions
Every day.
every day, and you feel that there's some sort of reason for all their actions doing this. Any other things that you've got problems with?
Following me down the street. People following me when I'm going to the shop. It's happening more and more. I mean, I've tried to explain to my friends about it. They get really agitated. They think, they think I'm off my rocker, but they don't see it. They're not living with it every day.
Okay. So your friends are worried as well?
Yeah.
So
Well, worried, or I mean, I don't think they're on it. I don't think, but they know a lot about what's been going. I don't know. Maybe the police have been talking to them or something, or maybe my neighbours have been talking to them.
Okay.
I don't know. Again, you'd have to ask them. But it's hard. It's hard to know. It's hard to know who to talk to, because they all,
So
they're all involved.
So this started happening a few months ago. Has it had any other effects on your life?
Well, yeah.
Such as?
Can't really go out. Well, I can, but I know what's going to happen if I do. So I'm just trying to stay low key. I'm trying to stay out of people's way. I've hardly slept. I've hardly slept for the last, I don't know. I can't remember the last time I got more than 4 or 5 hours sleep.
So what disturbs your sleep?
I don't sleep until, I don't tend to go to sleep until after 2, 3. Well, I'm sure that they've turned everything off.
Right, okay.
Downstairs, and just can't. I'm worried about it.
Any problems watching the telly, listening to the radio?
Oh yeah. They're using the TV as well. They're using all. They've got all this technology, obviously. I mean, I know there's all these smartphones and whatever now. All they need is one of them, and they can just. But yeah, TV. They've got the local news. If ever I watch that, there's always some little comment. There's always something they say in there at the end about what's been going on. Pretty much every time I turn the TV on now.
Okay.
I mean, it's it's all just the cable, isn't it? So they could, for all I know, they've just plugged it into that.
What do you mean the cable?
The cable TV. It runs down the street. Everybody's got access to it if they know what they're doing.
So obviously, this is all very distressing. All the different things that are happening. Can I take you back a little bit and just find out a bit more about you? I think your doctor said you're age 29.
Yeah, 29.
Tell me a bit about where you were born, your upbringing.
All right, so you can present the AMC now.
Sure. Hi, my name is Dr. Namra. I wanted to present the MSE examination of a 29-year-old male, casually dressed, reasonably camped, dressed according to weather, fidgety, a bit anxious. In terms of speech, his speech seems pressured and a little bit high in tone. Emotion-wise, his mood they didn't assess, but he seems agitated. And in terms of perception, he has the delusions of guilt, delusions of persecution, delusion of reference, and delusion of broadcasting. His thought form is not linear, and in terms of insight, it seems impaired. They didn't assess cognition, and I think his judgment is impaired as well. So I think this patient is of high risk, or at least moderate to high risk, because of active delusions. And his history does not seem very reliable. The patient has good eye contact, so I think the patient has good rapport with the examiner. Thank you.
All right, thank you, doctor. All right, so what were the delusion you said again, please?
A delusion of guilt, delusion of persecution, delusion of reference, and delusion of broadcasting.
Good. Okay, why guilt?
Oh.
No, in here there will be no guilt, okay? But
Yeah,
others
sorry.
are fine. That's fine, Dr. Nomra. You did really good. But because you have some time in here, just I think be a little bit slow so that examiner can take everything that you are saying, especially when you are saying something very important like the delusion one. Just be a little slow so that examiner don't miss it. Like I asked you again, examiner will not be able to do that. So just say that like during the specific point, just be a little slow so that examiner can just tick those points. Okay,
Oh,
so that's
all right.
important because sometimes they will just miss it. So that's other than that, everything was good. So appearance, you say that yes, patient is well groomed, dressed appropriate. Patient is restless and fidgety a little bit. But yes, he is sitting in a stooped posture, as you can see. Then speech was little bit high in tone and volume. Then emotion, they haven't assessed. So good that you say that they haven't assessed. So never comment on something which they haven't assessed in a video. So that's important. Perception, is there any perceptual disturbance, do you think, or anyone else?
Yes, I think he was having auditory hallucinations.
Good, very good, yes. Because he said that I can hear them talking, right, from
Yeah,
the other
yeah.
side. Now that's auditory. Now obviously it should not be a visual hallucination because actually he can see the people in the street. So it's not visual, but when he was saying that I can hear them saying about me from the other house, that's abnormal. So that you can say that it's most likely a auditory hallucination. The bugs, now about the bugs in the telephone, it will not be a tactile hallucination. Tactile hallucination means that if he was saying that they have put a bug inside me, or I can feel bugs crawling on me, that's tactile hallucination. Okay, but not this case. So that's good. And then thought form was linear. That's all right. Thought content. In here, there was delusion of persecution because he was saying spine, delusion of reference because everyone is talking about him. And also, yes, thought broadcasting, you can say, because TV, newspaper, he was talking about. Delusion of control is no, because in delusion of control, they think that someone is controlling them. Everything that they are doing, it is controlled by someone else, but nothing like that in here.
Uh, can we
Okay.
say that thought form is linear? Like when do we say
You
that the thought
can,
form is linear? Okay.
you can, because linear thought form means that if you understand what patient is saying,
All right.
now you could understand it, right? So if
Yeah.
you don't understand, then it's not linear, then it's the other form, like either it's a loosening of associations, tangentiality, all of those other things. But
All
as
right.
long as
Okay.
you can understand what patient is saying, you can say it's linear thought form. And thought content, insight, cognition, judgment was not assessed. So risk, yes, you can say this patient is a high risk because of active hallucination and delusion. Rapport, yes, the rapport was well built. And reliability, this is not reliable. So what you will say in here that the history is not reliable. So examiner might consider taking a collateral history from 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 the neighbors or friends or police. So
All
in
right.
here, you would not do that because you are not the part of this conversation, examiner, or you can say the counselor. Okay.
Yeah. Oh,
Oh, good. But you did really good. Thank you.
thank you.
No need to provide diagnosis and DD, Pavin. If they don't ask it, we don't say that. MSE presentation does not include diagnosis and DD. Now, it might not be visual hallucination because he just said that they might have put some bugs in it. That's how they know it. So if he says that I could see that there is a bug in the cable, then we could say that it's likely to be a visual hallucination. I haven't seen video coming in online exam, so it's mainly for face-to-face. Yes, so this case sometimes just only one task. You watch the video, that's the one task, and the second task is MSc presentation. Not always. It's not always that they will ask you 2 to 3 tasks. Sometimes just history, diagnosis, and DD can be there. But MSc presentation, like a video MSc presentation, is most of the time is like this because you can't give a diagnosis based on just this conversation. Okay, but if they ask you, then only you give it. It depends, but you don't need to give it promptly. All good. Now let me take a 5-minute break, and then we will do some other important cases. Okay. We'll do one of the risk assessment tasks, Dr. Femia. Okay, so that you get an idea about how to do that. Let's take a 5-minute break. Thank you. All right, everyone. So let's start again. Who wants to do the next one? I can see some of the others' name. I can see Dr. Ismotara. Do you want to do it now? Or Dr. Sumaya? Okay. All right, Dr. Ismotara, I'm just unmuting you. And then we can do with Dr. Sumaya.
Hello, doctor. Good evening. How are you?
Good evening. I'm good. Thank you. How are you?
I'm good, doctor. Thank you.
Okay. All right. So let me give you a case.
Yep.
It will be a little bit tough because the task is a little bit more than usual. Okay.
Okay.
So use
Okay.
your time correctly.
Yeah, I will, doctor.
And I'll give you 8-minute time to finish this one. Okay.
Yep. Thank you, doctor.
All right. So this is your
Yep.
patient, David. You can start.
Yep. Hello, I'm Dr. Ismotara. I'm the working doctor in this ED. Nice to meet you, David.
Nice to meet you, doctor. The code is great.
Yes, David, I can understand. David, today I'm going to discuss with you a little bit about your overall condition, but let me reassure you that it will be confidential between you and me unless it is harmful to you or anyone else, David. So, David, may I know your today's consultation with me?
Nothing. I don't know why I'm here. You can
Mm-hmm.
ask the police. They were just disturbing me in the street.
Mm-hmm.
I was just talking to God because I can talk to him. And like I think like the police is jealous about me. That's the reason I'm here.
No worries, David. I will try to manage to talk to them. No worries. So, David, can you please tell me how's your mood nowadays?
Your mood is good.
Okay, David, anytime if you feel that you are in a low mood?
Everyone feels that. I feel sometimes, but not now. I'm feeling good now because God is with me and I have the power to talk to him and no one can talk to him.
Okay, David. So, David, how do you sleep at night?
Yeah, I don't need to sleep because God is there.
Okay, so anytime are you traveling with to fall in sleep?
Sometimes not. God helps me.
How's your appetite, David?
Yeah, I eat what I can get.
Okay, so David, do you think that life is worth living?
Yeah, why not? Because as long as God is with me, what can happen?
Yeah, that's nice, David. So David, can you please tell me anytime you feel that you should end your life?
Hi, doctor. Why are you asking me to end my life? I'm fine. I'm doing all right.
Okay, David. So, David, now I'm going to ask you some screening question. It may seems to be weird. Just please bear with me. So, David, anytime if you feel or see anything that is not usually seen by people.
Well, what? I don't know. I know that people can't talk to God, but I can. But that's usual for me.
Okay, anytime have you seen that?
You're saying that to God?
Yes, David.
Uh, no. God is very busy. He can't come and show me. I can just hear him. He just give me some commands.
It's understandable. So, David, do you think that people are trying to harm you?
They can't harm me, doctor, because I have the power to stop them. But they are very jealous
Okay.
of me, and they want to do that, but they can't.
Okay. So, David, do you think that your thought is being broadcasted in the electronic media?
Yeah, like all the TVs, newspaper, they're just talking about me because I can talk to God. I'm the celebrity here.
Mm-hmm. Okay. So, David, do you think that do you need any medical help?
No, why I would need medical help? I have the God's power.
Okay. So, David, do you know where are you now?
Yes, I'm in the hospital.
Okay. Do you know who I am?
You are the doctor.
Okay. So, David, what's the day today?
Doctor, I live in the street. How I know what's the date today?
Okay. So, David, if there is any imaginary fire in this room, what will you do?
Nothing, because fire can't touch me. I have the power.
Okay. So, David, do you have any enough support at home?
God is great.
Okay. So, David, do you smoke, drink alcohol? May I know that?
Yeah, if I can get something in the dustbin, then yes, I can drink some wine. I don't have that much money to get lots of alcohol, doctor.
I'm sorry to hear that. So, David, are you enjoying to hang out with your friends or any family member? Do you have?
No one can be friends with me because I have some special power, and they just think I'm very different.
Mhm. David, are you sexually active so far?
No,
Okay. So, David, from my note, I got to know that you have a medical issue before. So, are you taking any medication for that?
what medical issue, doctor?
Uh, or like you have diagnosed with schizophrenia. Are you taking any medication for that?
No, doctor. I was feeling fine after taking the medication just for 2 days, so I stopped it, and I'm feeling good.
Okay, may I know why you stopped this medication? Any issues with medicine or any financial issues? May I know that?
No, I am feeling good, so I will take medication for that.
Mhm. Okay, thank you so much, David, for cooperating with me. Just excuse me for a moment. I'm going back to my examiner. Dear examiner, I want to present the mental status examination of my patient who is 30-year-old male brought by the police to me. Uh, On regarding the appearance and behavior, whatever I found, that patient is not well groomed, unkempt. Patient is in not dressed appropriately according to the weather. He is not maintaining eye contact properly with me. Regarding the speech, I found that rate and volume is increased and rapid pressure speech. Regarding the emotion, whatever I found that patient is in euphoric mode. I couldn't address the affect. Regarding the perception, I found the auditory hallucination. Regarding thought form, it's linear. Regarding thought content, I found that delusion of guilt, delusion of grandiosity, delusion of reference, and delusion of persecution. I couldn't found any overvalued ideas and loosening of association. Regarding risk, I found that patient is homeless and living in the street. And he don't have any enough support, and he's using alcohol at the street. So I think patient is in high risk. Regarding insight and cognition, patient don't have an insight and cognition is okay. Patient judgment is impaired. I couldn't maintain proper rapport with my patient. Regarding the risk, I think patient is in high risk. Regarding the reliability, the whatever the patient is shared with me, it's not so reliable. That's why I would like to take collateral history from the police uh, or relatives. Uh, relatives. So I think patient may need to admit to the hospital right now.
Enough. Thank you.
Yeah.
What's the cause?
Okay. Okay. So cause that can be relapse of schizophrenia. It could be drug abuse, or it could be acute psychosis due to ongoing infection.
Infection.
The non-healing leg ulcer. Sorry, doctor, I don't know anything else.
That's fine. That's fine. So that's a good point. Now, about the non-healing leg ulcer, at least ask one question that I
Yeah,
can
doctor,
see that you are having
yeah.
some ulcer. So that was one thing. Like that means that you don't care about this non-healing leg ulcer the patient has got.
Later,
Okay,
I
no,
just
now this kind of
recognized, yeah.
yeah. No, that's fine. But there's one like anything in the question which shows that patient might have like a stitch in the head or maybe a little bit of injury in their head. Always just one sentence that I will just take care of it. Or I can see that there is a ulcer in your leg. Is it painful? Is it bothering you? So just
Yeah.
one thing, and then you can just say, "That's all right. I will take care of it." So that means that you are taking care of the whole patient.
Yeah. Yeah.
Now, you did really good, Dr. Ismotara. So the calmness in the voice is very important, which you have. Now, in
Thank
the
you, doctor.
psychosocial history, you gave the confidentiality statement that was really nice. Now, all the history that you asked, that's fine. I would say just change the one approach, which means that if your patient saying that God is great, I can hear God, maybe just start asking questions about the hallucination first, and then
Okay.
go to the whole other format. In that way, it seems that you are asking relevant questions rather than just following or memorizing a particular format. Everyone knows that you are like everyone has a format in their head, but you don't need to show that to the examiner.
Okay.
So
Yep.
that's a good idea. I always say that if you get from the patient that patient having a hallucination, just ask question that if I say that I can hear God, so at that time you can ask that, well, you can hear God. Can you also see him? No, doctor. And how long you are feeling this way? Because you need the duration to give the cause of the symptom. Because duration will be important. That is it a schizophrenia from illness or is it a schizophrenia? Okay. So that's
Yes, doctor.
important, the duration. Apart from that, then you can just go to the mood, sleep, appetite, all the other questions one by one. Don't forget to ask all the delusion question here because it's likely schizophrenia question. Okay. So in this case, all the questions, delusion of control, delusion of persecution, every RCGGP, even if you can ask thought insertion, thought broadcasting, all of those are important. You did ask about thought broadcasting, that was good. But I think like a couple of other questions like control you did not ask. Do you think people are talking about you that you can ask? Okay. So that's what I think like very important in any schizophrenia questions. Then quickly, you did ask about insight, cognition, judgment. SADMA, you asked home situation because that's a part of risk assessment. The MEC presentation was good. Now, couple of things I would say that appearance, that's fine. Speech, it's not a rapid pressure speech in here. Rapid pressure speech was the one that I did the mania case.
Okay.
That's rapid pressure. This one was like, you can say normal. You can say that the
Okay.
volume of the speech has been increased or tone might be increased, but it is not a rapid pressure speech. Rapid pressure means just talking and talking, like you can't even stop the patient. That's rapid pressure speech.
Okay, doctor.
In terms of emotion, say that what patient said about their emotion or mood. So patient said that I'm feeling good. So you will have to say that as part of the emotion, patient mood is good and the affect that I have observed is disturbed. Okay, this disturbed means any schizophrenia or psychotic patients, affect is disturbed. Okay, even if they say that it's good. Then perception, yes, auditory hallucination is here. There is no visual or tactile. Thought form was linear. You can always say that there was no loosening of association. Thought content, delusion of grandiosity is there because of the special power. Delusion of reference is there because everyone is talking about him. Delusion of jealousy, you can say. Delusion of persecution, you can say, because I say that, yes, I know that they are going to harm me, but they can't. Then you can also, I think you said about the thought broadcasting. I can't remember. Then insight, cognition, judgment, you did good. 3R also good. Now, during your 3R, don't bring the risk assessment because you have another task of risk assessment. Just do it at that time. In that way, you could save time.
Okay. Yeah.
You can just say that patient is high risk because of active hallucination and delusion. Then you can go to the full risk assessment at the end when you are saying what's the cause of the symptom. In exam, one of the important thing that if it is not written in the task that discuss this thing with the examiner, always discuss it with the patient. Most of the time, it will be written very clearly that who to discuss with. Are you going to discuss it with the patient or examiner? But in case it's not, it's always a good idea to discuss the diagnosis with the patient rather than examiner. If they want any particular thing to be discussed with the examiner, they always write it in the task. Okay? But
Okay.
most of the
Yep.
time, you will not get this much confusion in the exam. So you will have to discuss with the patient that this is most likely you are going through a condition called schizophreniform illness or a relapse of schizophrenia. Likely that is a relapse because patient was not taking any medication. So this is what we normally say, that you can say that I'm David, I'm very happy to know that you are feeling elated and good. It's a good feeling to be positive as you are. The only problem with it is that sometimes this intense joyous feeling can detach us from reality and things can quickly become overwhelming and confusing. It's important that you know that this is a direct result of you not being on your medication, and with the recommencement, you will no longer be a risk to yourself. Most likely you have got a relapse of schizophrenia. Your non-compliance paired with your drug use, which is also very important factor of provoking these attacks. Being with, like, you can also say that because you are also living in the street, you are having financial issues, and also your belief about talking to the God and taking high risk, it's concerning me and putting you in a high risk of harm yourself. So that's the reason I would like you to stay with us in the hospital for a while where you will be managed appropriately. Okay, so that's up to that you can discuss. Now the risk assessment, it has some point to talk about. So normally we follow this SAD-Pearson formula. So SAD, then Pearson. SAD-Pearson is a mnemonic for risk assessment. There is no need of giving any point in the exam. But if you can just say this point that your age, your sex, your history of depression, previous suicidal attempts, all of this put you in a high risk. So what is this SAD person? SAD is for sex, which is male, is high risk. Age, less than 19, more than 45, high risk. Any history of depression, hopelessness. P for previous suicidal attempt or any other psychiatric care in the hospital. E for excess alcohol or drug abuse. R for rational thinking loss. That's the insight. S for separated, divorced, or widowed. O for organized or serious suicidal attempt. That means if someone has got a plan of suicide. N for no social support, like this patient who is living in the street. And another S for if a patient says that he is having a future intention of suicide. So basically, if a patient is having features of depression or hopelessness, you can also think about active suicidal thought, future intention, previous attempt, who is drug abusing, lack of financial support, lack of social support. All of this can put a patient on a high risk. Okay, so mainly when you are giving the risk assessment, talk about it. If a patient having active suicidal thought, if a patient having active hallucination, delusion, loss of insight, loss of judgment, lack of social support, financial support, drug abuse. Okay, so these are the main points that you will need to talk in the risk assessment.
Yeah, thank you, doctor. Doctor, just one confession, like patient is telling me I'm in a good mood, but I couldn't see her expression, her like her affect. So should I mention that
Yeah.
in the MSA presentation? Or
No, usually like because if you hear the patient's conversation, then you can understand that patient
okay.
is
Yeah.
actually disturbed, right? The affect
Mhm.
means what you actually feel about the patient. It's not about what you see. So
Oh,
that means
okay.
it's not about what patient says. It means about what you feel about the patient. If you feel that patient's feeling is good, then you can say that affect is congruent. But psychotic patients' affect is usually disturbed.
Yeah. Thank you, doctor.
You did good, Dr. Ismodara, so keep it up.
Thank you, doctor.
Thank you.
Thank you.
Sorry, I muted you. So, Dr. Vavin, how was the ulcer? Yes, to mention about eye contact when we can't see him. Yes, so that's fine. So it depends what you get in the exam. Ulcer, you should say that you would take care of him. How to rule out delirium? To rule out the delirium, the cognition is the important part. If a patient is oriented to time, place, and person, they are not delirious. There is no need of asking MMSE question unless in the exam they say that find out the MMSE of the patient. There is a case where you will need to do both MSE and MMSE. If that is the thing, then yes, you will need to add some MMSE question. Otherwise, no need. You can do that, Dr. Aman. So smoking, alcohol, drugs in one sentence. Most of the time, Dr. J, that they mention that like in exam, it is very clear cut that where are you? You are in the ED or GP setting, and what's your position? I have seen that it's always very clear cut. It's not confusing in the exam. So you will know that. If you don't know that what's your position, just say you are a doctor in here. All right, cool. Let's do another one. I think we asked Dr. Sumaya, right? Yes. So let me unmute you.
Hello, doctor.
Hi, how are you?
I'm good. How are you?
I'm good, thank you. Okay, so let me give you a case. Okay, just one thing I have added here that just explain the diagnosis also. Okay, so this is your task, Dr. Sumaya. Your 1 minute time just started.
Okay.
All right, so this is your patient. Your patient's name is Elena. You can start.
Hello, Alina. My name is Dr. Sumaya. I'm one of the doctor working here today. How are you doing?
Yeah, doctor, I'm fine, thank you.
Okay, it looks like from my notes that you are experiencing some chest pain. May I ask, are you in pain right now?
No, doctor.
Okay. Before proceeding further, I assure you that whatever we discuss here will be highly confidential and less harmful to you or to anyone else. I'm going to ask you a few questions regarding your condition. Is that all right?
Yeah.
So, Alina, let me know, how's your mood these days? Are you feeling low, feeling high?
I'm all right, doctor, but it's just about the incidents that happened in,
Mhm,
it's not just now. So it happened about 4 months ago when I was there for the first time in the postnatal class,
mhm,
just after my delivery.
mhm.
So I had an intense feeling that I was going to die. And that
Okay.
feeling just coming again and again throughout these few weeks. I
Mhm.
just don't know why this is happening. And I think like I have got some serious issue in my heart.
Okay, I'm so sorry that you are feeling this way. I assure you that I will definitely help you, and it's good that you are coming here. And it looks like you are worrying because of the pain. Do you think, have you ever experienced this pain before?
Not before that time. So the first one was 4 months ago.
Mm-hmm. Okay. And after that, you haven't feel it the same way.
No,
Okay. Let me know if you think like you're having a recent weight gain or weight loss.
no, doctor.
And can you tell me a bit more about your sleep? Are you having enough sleep, wake up fresh in the morning?
Yeah, I can, but sometimes I just keeps on thinking about all the things going on, and sometimes
Mm-hmm.
my sleep can be disturbed.
Mm-hmm. Okay. And excuse me if I'm asking some silly questions, but these are the part of the consultation. So, do you think someone is spying on you and looking after you?
No,
Okay. Do you think someone is putting thoughts in your mind?
no,
Okay. And do you think like you have some special power that others don't?
no, doctor.
Okay. Do you think and feel or see and hear it's something that you think others don't?
No,
Okay. And you are here for the professional help, is that right?
yes,
And just one more question. I'm sure that it's not been so long. So if there is a fire in the room, what will you do in this situation?
I'll run.
Okay. Thank you so much, Alina, for all the answers that you have provided. I will assure you that I will be back to you after speak to the examiner. Hello, examiner. My name is Dr. Ali. I'm one of the doctor working here. I'm going to present the mental state examination of my patient named Alina, age 27 years old. She's wearing appropriate according to time and season, well kept. However, just a bit worry and anxious about something. She's friendly to me and answer questions appropriately. Her speech is normal in tone, volume, and speed. Her mood is good, and that is quite relevant to her affect. She's making enough eye contact and a good eye contact. She described she's not experiencing any auditory, visual, or tactile hallucinations, no delusion of grandiosity, no delusion of perception, no delusion of jealousy, and no loosening of associations. She's not having suicidal ideation as well. Her insight is intact, and judgment is intact as well. She's oriented. I forgot to ask about the orientation of time, place, and person. I try to build a good rapport with the patient throughout the consultations. Uh, uh, she is okay, and I think the history is reliable, and we can proceed further with the explanation of the diagnosis. Um, Hello, Alina. I'm going to explain you the condition you were having 4 months before. Are you with me so far?
Yes, doctor.
Okay. Alina, actually, this is a condition known as postpartum pneumomediastinum. It's a complaint mothers are having while deliver the baby. It is a very rare condition after labor and delivery. Um, there are a few. It looks like you have experienced this condition, but you are coming late for the consultation. But that's too not too late. I understand that you are fear about heart attack, but it is not the case. We are going to arrange some investigation for that. Basically, in this condition, the air is leak into the okay, so I'm making a diagram for better understanding. Our heart is being surrounded by another organ known as lungs, and they are enclosed in a cavity known as pneumatic cavity. If I'm sorry for using the medical jargon, just because mother body is so exerted throughout the labor, so air is being leaked into the mediastinum and causing some compression effects over there, making the pain that you have experienced that is quite intense at that time. Are you with me so far?
Yes, doctor.
Okay, because of the pressure effects, you are experiencing this pain. Um, what I can do is I'm going to arrange a chest radiograph, a chest X-ray, and we will see if there is any problem going on still now. Um, uh,
Time up.
what I can do now,
Time
okay,
up. Thank you, doctor.
thank you.
Okay. Thank you, Dr. Somaya. Now, I know that this is a little bit of like a tricky case because we haven't discussed this kind of cases yet in the class. Now,
Yeah.
the main thing always, Dr. Somaya, is that find out a little bit more about the incidents. That's called open-ended question. So ask that what exactly happened in that postnatal class. You would find out everything if you just ask that question, because I would give you every information. I was just waiting for that question. So even still, I wanted to give you a little bit of those, but when you did not ask more about those symptoms, I did not give it to you. So important thing that you are learning today is that don't just assume that this patient feeling that something is wrong in the heart. It is something wrong in the heart. It might be something else, right? So if you ask in detail in here, then you would find out much more positive findings. So I would do this case, but let me just ask another one to do the same case. I'll see that what they do, and then we will come back to you. Okay?
Okay, thank you, doctor.
Thank you, doctor. But you are doing good. I understand that you might be very new and beginner, so don't bother with that. You are just still learning, and
Yeah.
you will see that how the case will turn around. Okay? But the important thing, always remember in your exam perspective, is that making sure when you do a psychiatric case is that just try to mail down to the patient, which means that in the patient, show the patients your lot of empathy. Say that I'm very sorry that you are feeling this way, but you are here with me now, and I'm going to take care of it. So giving some hope to a patient means a lot. And someone who is 27-year-old who thinks that they are getting a heart attack, obviously they are stressed. And other important part is that it's a postnatal class, 27-year-old mother. That means she might be still in that period where she can get a postpartum depression. So you can ask the patient that, congratulations of your baby. Is this the first time you are being mother? How are you feeling? Are you coping up well? So all of these things are very important, and it means that you are a very caring doctor. And the examiner looks for this kind of qualities when you are going for the exam. Okay, so don't bother, because you will learn how to deal with these things. But yes,
I have
the
a
questions
question.
asking and everything is fine.
Yeah, I have a question actually. I'm just a bit confused that either I have to go with the pain cluster, ask about Socrates, or either I have to go into depression cluster or asking psychosocial history. That's why.
No, that is fine. It's the confusion is good, because the thing is that when you are confused like this, you just need to find out, are you having the chest pain right now, or what happened with the chest pain? Because I said, no, I don't have any pain at the moment, which means that it's not something wrong with the heart. If it is a heart attack or any other arrhythmia, I would have the symptoms right now. So that's one of the things, that if you go into the detail, then you will find out where to go. Are you going for the pain, or are you going to the psychosocial? Okay. And another thing, that we just need to find out one thing, that are you having the pain at the moment? No, doctor. That's the time you give the confidentiality and you ask more detail what happened. Then you will find out what exactly happened, and then you will go to the psychosocial history anyway. Okay.
Thank you, doctor.
All right. No problem. Now, is there anyone else who wants to do a case or like this? It would be easy for you because you already know a lot. Not Ismotara. Obviously, no. Someone else. Dr. Hina, yes, come on.
Hello, sir.
How are you?
I'm good. Can you hear me?
Hear you. Yes, all right.
Okay.
So
Okay, can I start?
happy to start right away. Yes.
Yeah.
So
I
just
can do.
1 second. Start.
Okay. Hello. I'm Dr. Hina. I'm one of the doctor here. From the notes, I came to know that you are experiencing chest pain after your postnatal class. Can you tell me what happened there? And let me reassure you that whatever we are. Let me reassure you that whatever we are talking today will be between you and me, unless it is harmful to you or others. So can you tell me what happened after your postnatal class?
Yes, doctor. So what actually happened is that now I'm having a 5 months old baby. So initially, just after delivery, I went to the postnatal class, and I think that was 3 months ago. And that was my first postnatal class. And I was already stressed about what's going to happen and what I'm going to learn. Am I going to do best for my baby? So
Mhm.
just at one point, I started to feel like I'm having a heart attack. I was trembling. I was feeling palpitations. I was having chest pain. I
Mhm.
was feeling sweaty and feeling like someone is just choking me.
I'm
And
so
since then,
sorry
I'm
to.
just
Mhm.
getting this. Yeah. Since
Yeah,
then,
I'm
I'm
so
just
sorry to hear
not
that.
like before.
Hmm. I'm so sorry to know about your condition. I'm so sorry that you have to go through that condition. So, can you tell me that was it the first episode that you have experienced such symptoms?
Yes.
And what happened after that? Were you good enough to go home, or did you
No.
experience any
So
loss of consciousness?
no, actually. So they actually called the ambulance and they took me in the
Okay.
hospital. But they have
Okay.
done all the investigations on my heart and they haven't found anything
Hmm.
wrong.
So everything was normal, right? Yeah. So any recurrence of what happened that day? Did you experience anything
Yes, since
again
then I have
similar
got
to that?
multiple episodes. Yeah,
Hmm. And are you worried about that similar thing would happen again?
I am worried because it happened like quite a lot since the last few weeks and it's just getting frequent. So at
Hmm.
one point I just stopped going outside because I'm embarrassed. What if I start to feel these things when I'm with my friends or in a crowded place?
Yeah, I understand. I'm so sorry that you have to go through this. So can you tell me about your mood? How is your mood?
I feel very worried about it at the moment.
Okay, I'm so sorry to hear that. And can you tell me, these are some screening questions that we ask from every patient. So can I proceed?
Yeah,
Yeah, can you see, feel, or hear things that other do not?
no, doctor.
And can you tell me that, do you think that someone is spying on you or trying to kill you?
No,
And do you think that you need medical assistance, medical help?
yes, doctor.
Yeah, can you tell me that where are you right now and who are you talking to and what's the time?
Yeah, I'm in the hospital and talking to you, doctor. And
Hmm.
I think it's Wednesday.
Okay, that's good. And for example, if you suppose that there's a fire in the room, what will you do?
I'll just run, doctor.
Hmm. Okay, thank you. I would like to get back to my examiner and then I will get back to you. Thank you. So, dear examiner, I would like to present the MSE of my patient, 27-year-old mother who experienced a chest pain in postnatal class, and she's worried about a heart attack. On appearance, she is well groomed and well kept. She is wearing the clothes according to the weather. She was cooperative throughout and maintaining normal eye contact. Her speech was normal in tone volume. Her mood was low. That was congruent with the effect, and there was no tactile, visual, or auditory hallucination. Thought form was linear, and thought content was normal. There was no delusions, and her insight was intact. She was well oriented in time, place, and person. Her judgment was also intact. I was able to make a normal, good rapport with my patient, and the risk is low and the history seemed reliable. Now I would like to get back to my patient to explain the diagnosis to her. Is that okay? Hello,
Okay.
I'm back. So I would like to talk to you about your diagnosis. So can I proceed?
Yeah, sure.
Yeah, so I think the most likely diagnosis you are going through is panic disorder. It is a kind of condition in which you feel intense anxiety with symptoms like palpitation, sweating, shortness of breath, and loss of consciousness that you have told me about. So, this is a kind of normal condition and it is a treatable condition. And for that, I would like you to refer to psychologist. The psychologist will do CBT. And this is cognitive behavior therapy. It is a kind of talk therapy in which the psychologist help you to overcome your thoughts and help you teach how to avoid these attacks and how to overcome these kind of attacks. There are some breathing techniques which I will tell you, and psychologist will also tell you about. And you can follow these techniques when you are stressed or anxious. If your anxiety is still not relieved by CBT, then I would likely refer you to a psychologist, so that the psychologist will prescribe SSRI for you. And I will also likely like to refer you to social support group, in there you will meet people similar to you, and here is some reading material, and I will review on a regular basis. Do you have any questions?
No, doctor.
Okay. Thank you so much for your time, and it was very nice to meet you.
Okay. Okay, you too, doctor.
Yeah.
Okay, so you
Okay.
still have some time. Now, let's just stop the timer. You did good,
Hmm.
Dr. Hina. That means at least the diagnosis is correct. So that's really good. Now,
Okay.
the part of the history, what happens in here, that there is not much of a MSc presentation because most of these are normal, which means that you will need to take a little bit more history in here.
Okay.
Anytime if diagnosis is the task, that means that you need the diagnosis and also some other differential diagnosis to be ruled out. And especially,
Yes, sir.
it's always case by case. When you get a manic case or a schizophrenia case, you don't have much time because patient talks a lot. But in this case, our patient was not bothering you too much, and you could ask a lot of questions. And I was actually promptly giving you a lot of answers. What happened in the
Yes, sir.
exam, that they don't give you those like that much prompt. You will need to dig the questions out. That means if you think it's a panic disorder, you will need to find each and everything one by one from the patient. So
Yeah.
let's say in this case, what you will happen is that first of all, you will say that, yes, I'm Dr. Hina, one of the doctor here. It's very nice to meet you. Alice, I'm very sorry to hear what happened in your postnatal class. And I understand that you're worried about having a heart attack. But please don't get scared, because now that you are here, we are going to take care of you. And we'll find out what happened and why you're feeling stressed. I would like you to know that this is a safe place and you don't need to feel embarrassed about anything that's going on. And you can talk to me about any stress, any specific thinking that you are going through. And in that way, we can help you appropriately. Then give the confidentiality statement. Ask the patient, so would you please tell me a little bit more about what happened in the postnatal class? Then the patient will give all the information as I did. They might not give you all those symptoms that I said. Patient can say, I was in the postnatal class and then I just felt that I'm having a heart attack. Then you need to find out that, well, when did that happen? So 4 months ago. All right. So was there any particular symptom that made you to think that you are having a heart attack? Then patient will say, yes, doctor, I was having palpitation, chest pain, racing of my heart. I was feeling dizzy. Then you just need to ask more symptoms in terms of panic disorder. So what else patient feels? Patient have feelings of fear of dying, choking or smothering sensation, feeling very shaky, trembling, sweaty, or okay. Sometimes even they can lose consciousness. So and sometimes even tummy pain, difficulty breathing. So all the questions you will need to ask in here. After that,
Yes, sir.
to rule out the possibility of any heart related thing, you can always ask them that now let's not go in there at the moment. So after you have asked those symptomatic questions, then you ask that, apart from that postnatal class, did you have those symptoms any other time? They will say, yes, doctor. So how many times you had it so far? So 6 or 7 times. When was the last time? Just 2 days ago. Can you describe what were you doing at that time? So you are getting into the deep of this situation. You need to find out which brings this thing on. Because first one was in the postnatal class? What happened in the last time? And ask that, how about the previous one? So find out the detail that what she was doing and what brings this panic attack and what symptoms she gets, how long each of these episodes last, and how this get resolved. Does it get resolved on its own, or does she do anything that brings it down? Okay. Once
Yeah.
you have known about it in detail, then you can go to the full psychosocial history, which means mood, sleep, appetite. You need to find out the like suicidal thoughts of like any passing thoughts of harming yourself or others. Don't bother too much about hallucination, delusion. One question of hallucination, then 1 or 2 questions about delusion, insight, cognition, judgment. Now, you will need to ask the heads, SADMA. You will need to also ask some couple of other DDs. So some of the organic conditions, some of the psychiatric conditions. So in terms of organic, for a chest pain, you could ask about like
Thyroid.
like
Yeah.
any
And
thyroid, like any change of in your weather preference. You could
heart
ask
problems,
about,
etc. Yeah.
yes, any family history of heart condition. You can ask about like let's say any recent travel history for ruling out pulmonary embolism. You could ask about history of clot in the family. You could ask about history of any trauma to the chest. Okay, so just to touch the point of chest pain. And then about psychiatry, there are important differential in here. Like it could be a generalized anxiety disorder. So ask the patient that, are you an anxious person normally, or do you worry a lot about trivial things? Rule out
Yes, sir.
adjustment disorder. So anything particularly happened before this started. So any separation with the partner or anything particularly happened which can bring this thing on. You could also find out depression as a very important DD because it's a postnatal case. So ask about little bit that, do you feel interested in things that you used to enjoy before? So any loss of interest, any loss of energy, any sleep issues, okay? And do you feel
Yes, sir.
guilty about any things? So a couple of depression questions. So which means it's not about just MSE presentation, because you have to give diagnosis, these questions will come. Okay, if it was just MSE presentation, then you don't need to go in this much detail. But
Yes, sir.
any case, the case related relevant question should be asked if it is possible, even if it is a MSE case. Like the mania case we have done, if you have some time, always add mania related question. If it's a depression case, add a little bit of depression related question. Same with every case. It's about how much time you can accommodate. Okay?
Yes, sir.
Now, apart from the history, in the MSE presentation, everything was good. But there is a finding in the MSE. Anyone can tell me that what you can add here in the MSE presentation? To make it a little bit easier, when you ask this patient that, patient will say that, I'm really worried about heart attack. Okay, and I'm thinking that something is wrong in my heart. What does it mean? It means that patient having some overvalued ideas. Yes, Dr. Ismutara, very good. So overvalued ideas about these symptoms, because hospital already has done investigations. Everything is normal. Still, she is worried about heart. And that's a part of thought content. Thought content does not just mean that it's always delusion. Thought content also include overvalued ideas. And overvalued ideas includes eating disorder. Overvalued ideas include this like this feeling of symptoms related to some particular condition, like this one. And also, like if someone having obsessional thoughts. So there is an OCD case which also comes same like this. So in that case, that obsession is part of a thought content. Okay. So all of these things, like yes, polydysmorphic disorder, eating disorder, then any particular thinking about particular symptom, like if someone got a chest pain and they're thinking they have something wrong in the heart, even though you have said that everything is normal, that's also overvalued ideas. Okay, that's the only finding in MSE you might get. And explain the diagnosis that yes, it is a panic disorder with agoraphobia. there are particular questions. Panic attack means the brief period of severe anxiety symptoms when patient gets all the symptoms. If a patient keeps on thinking about the next attack, that's what we call as panic disorder. And single panic attack is not panic disorder. It has to be multiple panic attack to say that it's a panic disorder. And then because of panic disorder, if a patient stops going outside or in the crowded places, that's the time the term becomes panic disorder with agoraphobia. So that will be your diagnosis in here. Okay, we'll discuss this case in our course again because there is a case of panic disorder itself. So that time you will know a little bit more about it. Okay, so that's good, Dr. Hina. You did really good. Thank you.
Yeah, thank you, sir.
All right, so that's this case. We will just do another case, which will be a video presentation. Who wants to do the last one? Dr. Uzma, yes, we can do that. So let me unmute you. Can you hear me? Dr. Uzma, I can't hear you. Something is wrong in the microphone. Dr. Uzma? Are you using a microphone or headphone or just your phone? You can hear me, yes, but I can't. And your microphone is not also moving, which means that there is something is wrong in there. My laptop. You will have to join the audio in your laptop. Have a look where there is an option of join audio. No? All right. Let's try with someone else then. Yeah, that's fine. I think like there is a little bit problem in that. Anyone else who wants to do? Dr. Rebecca? All right. Let me unmute you. You can hear me?
Yes, sir.
Yes, good. All right, so let me give you a case, Dr. Rebecca. It will be a video presentation. So just like before how we have done.
Yeah.
So this is the case. Have you read and then we will start the video. Okay. Just let me know when you are done.
Yes, I'm done, sir.
Okay, so I'll start the video and then you will need to listen to the video. You can write anything you want on the paper. Once the video is stopped, you will need to present the MSE.
Yes.
Let's start.
Hi Andy, do you want to come on in and have a seat? I'm Dr. Taylor, I'm the on-call psychiatrist for this afternoon. I got a call this morning from your family doctor because I think you went to see him this morning along with your mum, and I gather that things have been a little bit difficult for you. You've had some rather distressing experiences. So I think your doctor thought it might be helpful for us to have a bit of a discussion about that to see if I could help. Would that be all right with you?
No, it's fine.
Would it be all right, Andy, for you to tell me a little bit about what's been going on?
Well, you're going to think it sounds stupid, but my housemates are working for MI5.
Right.
And they're doing stuff to my brain.
Okay.
And they're out to get me.
Okay. That must be very difficult for you.
Okay.
How long has this been going on for, Andy?
About 2 months.
Right. And how did you first work out that this is what was happening?
I came home one time and they'd moved the TV to the other side of the room,
Right.
and I knew then
And what was it that you knew at that moment?
that they were for MR5.
Right. Okay. Okay. So it's been going on a couple of months.
Yeah, this new lecturer started at
Right.
uni, and he works for MI5, and
Right.
he basically drafted my housemates in, turned them
Okay.
against me.
Okay. Okay. Now I've noticed a couple of times while we've been talking that you've sort of looked round you into the room as if you're checking for something. Could I ask you what's happening at those times?
Oh, I can hear them talking about me.
Right. Who is it you can hear?
My housemates.
Right. So that you recognise it as their voices?
Yeah, I can hear them all the time.
Right. How many voices can you hear, Andy?
3. There's 3 of them.
Okay. And do they sound real, like my voice sounds talking to you now?
Yeah, it's odd. It's like I can hear them when they're not here.
Right.
And
So what they're not when they're not in the house with you?
yeah, it's like they're in the other room or something.
Okay. Okay. And can you hear what they're actually saying?
Yeah, they're talking about me.
Right. Okay.
They're always talking about me.
Okay.
They're always commenting on everything that I'm doing.
Right. Can you give me an example of what they would say?
Well, like if I'm packing my bag to go to uni or something,
Mhm.
they'll comment on that, like he's
Right.
left the house now.
Okay. Okay.
Or, you know.
Anything else? Do they ever talk to each other, perhaps about you?
Yeah, that's what they do. I mean, and now they know. They've sort of twigged that I know about them now,
Right.
and they're saying like I'm making trouble,
Okay.
and that they're gonna sort me out.
Okay. Okay. What about actually talking directly to you in the way that I'm talking to you now? Does that ever happen, Andy?
No.
Okay. So you've been hearing the voices of your housemates. Have there been any other changes? Have there been any changes perhaps to the way you're thinking? Sometimes people tell us that their thinking changes in some way. So for example, they might feel that they're getting thoughts put into their head that aren't their own. Have you had any experiences like that?
Yeah, I do think things that aren't me. Like they're putting stuff in my brain. It's not me. I'm not thinking.
So different
like
thoughts in your brain.
Yeah, that's
right.
like it's stupid stuff as well. It's like the other day I suddenly just started thinking about some woman in Coronation Street. I don't watch any of that crap.
Right. It's not your kind of thing normally. Right.
They're not my thoughts.
Right. Okay. And do you have any idea how that's happening, or who's responsible?
It's MI5. It's this chip they've put in my head.
Right. Okay.
And I can feel it all the time.
Okay. So you're getting thoughts put into your brain that aren't your own. What about a different sort of experience? What about the experience that somehow other people are able to know what you're thinking, even though you haven't actually told them?
No.
Nothing like that.
They're just putting stuff in my head.
Just putting stuff. And can I just check, Andy, as well, that you're not getting the experience when your thoughts just stop altogether, like you have no thoughts left?
No. If anything, there's too much in there. I wish I could unplug it.
Okay. Okay.
Just get this thing out of my head.
Right. And you mentioned this chip or this device in your brain. Do you want to tell me a bit more about that?
Well, it's a tracking device, so they
Right.
know where I am at all times, and that I can feel it moving around, like rotating
so you can
around.
feel the physical sensation in your
Yeah.
brain. Okay. Okay. That must be very difficult for you.
I don't know why they're doing this to me. I've done nothing wrong.
Okay. Can I just check, are there any problems, Andy, with the rest of your body? Any changes in sensation or any bits that feel different in any way?
No, I feel fine. I'm not.
Right.
I'm not ill or anything. I just want this thing out of my head.
Okay. I mean, it sounds like a very difficult time for you. Can I ask you, Andy, how are you coping with all this? How's it affecting you?
Well, I've not been leaving my room much, and I sort of have to wait till they go out to go down and get some food, but they've been doing stuff to my food now, so...
Okay. Well, what do you think's happening to your food?
They're poisoning it.
Right, okay. Are you actually eating much at the moment?
All right, so you can present the MSE now.
Yes, doctor. Doctor, can I see the question? Dear examiner, I would like to present a case with a 36 years old patient who came to the clinic. On appearance, the patient is well kept and well groomed, and he's wearing according to the weather. And on assessing the speech of the patient, the tone is normal. There is no low tone or any precious speech. But the patient is looking around when he's talking. And on emotion cannot be assessed on the video, and also on perception, the patient is having active auditory hallucination, but there is no tactile or visual hallucination. On dot content, the patient is having a delusion of reference, delusion of persecution, and on thought, patient is having thought insertion as well. And on assessing the insight, insight could be impaired as the patient is having loosening of detached from the reality at the moment. And on cognition, cannot be assessed on the video, but could be impaired, and judgment could be impaired. And on assessing the risks, the patient is having active hallucination and delusion of reference and detached from reality. So patient is having high risks at the moment, and the report is good with the doctor and the history is reliable. Yeah.
Right.
So
thank you, doctor.
this is the end of, yes. Thank you.
Yes, all good. Thank you, doctor. So is it good with the MSc presentation? What has been missed?
Could it be thought broadcasting? Oh, sorry.
No, thought broadcasting was no.
Paranoid
Anyone
delusion?
else? Paranoid, you said about persecutory delusion, same. Yes, Dr. Bhavin, tactile hallucination. Why tactile hallucination?
Okay.
Because patient could feel the physical sensation of that chip, right? So when they can feel the chip, and it was confirmed by multiple questions from the doctor, that means it's a tactile hallucination. Okay, so that was the only thing I think you have missed. Now, yes, appearance, patient was all right. Now, in the appearance, you have to say that patient was responding to some unseen stimuli. That's the time when patient was looking in the room. So normally we say that patient was responding to some unseen stimuli. Okay, and in case of speech, fine. In the speech, we don't say that patient was responding. In emotion was not assessed, but always you can comment on the affect. So affect, you can say in here that emotion was not assessed, but the affect that I have observed seems disturbed.
Yes. Yes.
Perception is auditory and tactile hallucination is positive here. Thought form is linear, you can say. Thought content, patient having delusion of reference, delusion of persecution, and thought insertion. That's right. And what else? So insight, cognition, judgment was not assessed. The risk, patient is a high risk because of active hallucination and delusion. The doctor was able to maintain a good rapport with the patient, and the history is not reliable. Any if a patient having psychosis, it's not reliable. So you will need to take a collateral history from the mother, because the psychiatrist was talking about the mother. So you can say in here that the history was not reliable, so the doctor might want to take a collateral history from his mother. Okay. And yes, speech in here, you can say that patient was talking a little bit slow. So you can say the speech was slow in volume. And never comment on anything that's not been done. That means it does not mean what you think, that if you think that patient might have a loss of insight or cognition or judgment, you don't need to say that. You just say that insight, cognition, judgment was not assessed. Same with the emotion. If you think that patient was sad, you don't say that emotion is sad. You'd say that affect was disturbed. Okay. So you can't comment on the mood. Mood is what patient feel.
Yeah.
And apart from that, Dr. Amal, there was no delusion of control. They did not say that, the patient did not say that they are controlling me. They only said about thoughts. That means thoughts are getting inserted. Okay, so that's good. To see that how usually this video, this will be the video cages. It's very important for exam. It's not very hard, but if you miss a single point, they will fail you. Just because it is not very hard and you're not needed to take any history, just watch the video and get the findings. So even a small amount of mistake, they don't like it and they will just fail you.
Yes. So
and
doctor,
do we get a paper? Yes.
Yeah.
Yes. Yes, doctor. Tell me what you want to ask.
Yes. So I shouldn't like do any take any personal opinion that is not assessed. So I should just say insight, cognition, and judgment was not assessed like that.
Yeah. That's
so
right.
I shouldn't
you just
give
say
my
that it was not
personal
assessed.
opinion. Yeah. Yeah.
No.
Yes, I get it.
Okay, good.
Thank you,
Thank you,
doctor.
dear. Now, Dr. Javeria, yes, do we get a paper to write down findings? Yes, you get a paper. You can write anything. I would say just write the aseptic J3R in the paper and just write your finding. And then when you are presenting it to the examiner, you can just have a look and present it. Okay, so that's all about our MSE cages tonight. Now, you guys know that this is a part of our 2 weeks free session. Many of you are already aware of the course, but as part of the 2 weeks free session, at the end, normally we go through the course durations, any questions about the course, and also the video of the full course. So if you just want to ask any questions, feel free to ask it. I will just unmute you, so you can ask questions by your mic as well, so you don't need to write everything. Okay, so this is a time where you can ask questions about the course and anything that you are not understanding, anything you are confused about. Let me go through the video of the course so that you can have some idea. And then if you have any questions, you can ask me. Okay, so I'll just show you our course video and you can just have a look how the course is going to happen. Just give me a moment. All right. Let me just open the video. So this is actually our course details. So you can just go through that and have a look. If you're still having any question, just ask me now. Yeah. Thank you. All right, so that should give you a little bit of idea about the course. Now, apart from that, you will also, we try to add few classes based on your like your registration, as you already had one class with us, I think just few days ago, about the job, the CVs, registration pathways. So time to time, we will have some classes on that. We are trying to add more sessions in the course just to accommodate that. If you have guys any questions, anything that we can help with your registration or job pathways, some of the classes will be added extra as part of that. So That's one thing that's added. There is also availability of CPD claims, as we discussed in our previous session. So course has almost everything that you really need to pass the exam. And if you can finish everything in time, there is nothing you need. There's everything in the place, everything is well organized, and it's getting updated every month. So there is nothing else that you will need to think or hear or even you need to worry about. So we are the one who is going to worry about your passing exam. You just need to follow the guideline and do a lot of role play with your partners. Okay. Now, any questions? And how you join the course, Dr. Dikshit, is that either you can contact us through the email that is given, or you can always inbox me. If you are in the First Aid AMC clinical group, you can always inbox me and we can just, I can always send you the details. Any problem with the payment, you can always ask us either in the email or in the inbox. We are more than happy to help you. Okay. So payment, if you have trouble to make the payment in the software or in the website, you can always ask a different invoice from us, and we will just send you the invoice. You can pay through the invoice. You get that, Dr. SK, that you get a paper in every station to write down if you want. You get recording of the classes in the portal, and the recording will be there for a prolonged time, even after finishing the course. Yes, the first 2 weeks of the new batch is free, which means it's free for everyone. Anyone can join and get an idea about the class. And after the first 2 week sessions, then only the course students will be able to join the session. We made a little bit of time duration between today's class and the next class. As you can see, it's mainly for updating everything in for the new batch and adding everything to the portal. So it takes a little bit of time. So that's the time duration which we have taken, our team has taken to add everything in your portal. And then we are going to add the candidates to the portal so that you can go through everything. Usually we add everyone after the free 2 week session is over. But if any of you if you confirm that yes, you want to continue the course, then we will add you anyway. Okay, even before 2 weeks free session is done. And the class schedule, Dr. Manvir, is given in the First Aid AMC clinical group. So if you just go through that, you will be able to find it. I can see the next class is on 11th of December. That class will be with Dr. Cynthia. And Dr. Cynthia is one of your mentor who is going to take the role play sessions every week. Okay, so you'll get to know how she is taking the classes. And after that, we have back-to-back classes for 12 December, 17 December, then 21st and 23rd. Okay, so have a look at the first 2 weeks classes schedule. After that, after 23rd, you will get the full course schedule for only the batch students or only the course students. But until the 23rd of December, all these classes is free for everyone. So you can always join us, and the Zoom ID password is same for all the classes. And you get access to the portal until you pass your exam. All the notes and everything, just the video recording access will be for 10 months total. Okay, so that's all about the course. If you guys have any questions about the course, you can always ask us during this 2 week session. If any of you wants to start the process of enrollment, just make sure you talk to us either through the email or through the inbox in Facebook Messenger, because it takes a little bit time to get to know a course. And first you send a message, we answer your questions, you make the payment, we add you to the course Facebook group. So a lot of things goes on. It takes a little time. So keep your patience. We are dealing with like a huge number of candidates during the admission time. So if there is a little bit of delay of answering, don't get stressed about it. We will always get back to you. If you don't hear from us in 2 days time, please just ask another message or send another message so that you don't fall behind. Okay, so that should be all about it. Any other questions, any confusion, feel free to ask. Okay, we are always more than happy to answer any silly questions that you have. Every question is important. Okay, take care, have a good night.